myself Dr. Mritima, ENT resident, demonstrating before you general examination of patient having thyroid swelling. Obesity is seen in hypothyroidism. Hyperthyroid patients usually are thin and underweight, and carcinoma usually patients are cachexic and anemic. Regarding facies, usually hypothyroidism, dull or mask-like facies are seen. In hyperthyroidism, patient is in agitated state or tense face, and exophthalmos or excited face is there. Regarding intelligence, in hypothyroidism, usually low IQ is seen, usually in children. In hypothyroidism, dry and inelastic skin is seen. In hyperthyroidism, usually there is a moist skin with hot and moist palm. Regarding tremors, usually fine tremors is seen in hyperthyroidism. Then आप अपना हाथ ऐसे करें. As we can observe that there are no any tremors. So it's not a case of hyperthyroidism. जी बाहर निकालिए. अंदर कर दीजिए. On protrusion of tongue also we have observed that there is no tremors. So usually fine tremors are features of hyperthyroidism. In hyperthyroidism, rapid or irregular pulse is observed, and usually sleeping pulse rate is counted in hyperthyroidism. In mild hyperthyroidism, less than 90 beats per minute is seen. In moderate, 90 to 110, and in severe, more than 110 beats per minute pulse is observed. In hypothyroidism, there is usually bradycardia. There are various eye signs seen in hyperthyroid patients, like lid retraction, which is because of overactivity of levator palpatory superioris muscle. Second, exophthalmos. As there is no exophthalmos because eyeball is not pushed forward. Third, von Riffel sign, which is upper eyelid lag. Fourth, Geoffroy sign, which is absent of forehead wrinkles. In Geoffroy sign, as wrinkles are present, so it's not a case of hyperthyroidism. Steelbox sign, in which there is staring look of the patient and there is infrequent blinking. Next is Mobius sign, in which the patient is unable to converge the eyelids. Next is Dalrymple sign, in which the upper sclera is visible due to retraction of the upper eyelid. Next one, ophthalmoplegia is also seen in hyperthyroid patients due to weakening of extraocular muscles of the eye. And chemosis is seen due to edema of conjunctiva because of obstruction of the lymphatic and venous drainage due to increased retroorbital pressure.
Hello everyone, this is Dr. Yash Gandhi, ENT resident. I am here to demonstrate inspection method in a thyroid swelling. Firstly, if the thyroid swelling is not easily visualized, there are three methods to demonstrate the same. First is Pizzillo's method. This method makes the anterior thyroid neck swelling more prominent, so the examiner can easily appreciate the swelling. On inspection, we can see the left thyroid neck swelling over here. If the differentials will be in Pizzillo's method, if the swelling is uniform on both sides, the differentials may be colloid goiter or it can be Hashimoto's thyroiditis. And if it is unilateral, like this one, so it can be ipsilateral colloid nodule. Then secondly, it can be inspected on the basis of movement with swallowing. Benji, thuk nikal. और एक बार और एक बार. If the swelling is moving with the movement of swallowing, it is indicative of a thyroid swelling. The reason behind it is the thyroid gland is attached with the larynx. So on deglutition or swallowing, the larynx moves, and along with that the thyroid swelling moves. The differential is thyroglossal cyst, which moves with deglutition and also moves with protrusion of tongue. Then the जीभ बाहर निकालें. As you can see in this case, the swelling does not move with protrusion of tongue, so we can easily rule out thyroglossal cyst. The second differential is subhyoid bursitis, and the third one is prelaryngeal and pretracheal lymph nodes. Those move with deglutition but not with protrusion of tongue. And now third case, which is atypical, showing retrosternal goiter. In retrosternal goiter, usually we are not able to demarcate the lower border of the swelling. So in such cases of retrosternal goiter, we have to watch for dilatation of subcutaneous veins on upper anterior part of thorax. In this case, as you can see, there are no dilatations seen. The skin is clear, so we can rule out retrosternal goiter. Also, the lower border of the swelling is demarcated over here. Let me say that. Demarcated over here. In retrosternal goiter, on the other hand, we cannot demarcate the lower border of the swelling. Thirdly, to confirm the diagnosis, we can do one exercise where the heart as a refer to the candle. This is called Pemberton sign, and this is the if it elicits positive, it shows a facial congestion, which is due to engorgement of the veins above the swelling, due to the swelling which compresses the major vessels. In this case, it is negative, so we can rule out retrosternal goiter.
Hello everyone, myself Dr. Maitri Parmar, ENT resident. Today I am going to demonstrate the palpation of thyroid gland. Firstly, we will palpate the thyroid gland from behind. Now we will palpate the thyroid gland with both the hands from behind. Second method is Lyes method. We will examine the thyroid gland from the front. We will slightly flex the neck and we push the thyroid gland from one side and examine from the other side. Now we will do third method. Third method is Lyes method. In this method, we examine the thyroid nodule with the finger and ask patient to swallow. We also look for whole gland enlargement, as you can see in this patient. Now we will see for the surface of the enlargement. As you can see, there is a regular surface, no any abnormality seen. Smooth surface seen in primary thyrotoxicosis and colloid nodule, and vacillated surface seen in multinodular goiter. Now we will check for mobility of the nodule. Nodule may be mobile in horizontal and vertical dimension, as you can see. And nodule can be fixed in carcinomatous condition. Now we will see for the get above the swelling. In this test, we have to slightly mark the lower margin of the swelling and ask patient to swallow. As you can see, we can easily feel the lower margin of the swelling. Now we will see for the pressure effect. Some major gland swelling shows pressure effect. One is the Pocher's test. In this test, we slightly push the swelling from lateral one side and we can look for stridor or difficulty in breathing. Other one sign is dysphagia, which is seen due to compression of esophagus due to the swelling. Other one is sign seen is dyspnea, which is seen due to compression of trachea by the neck swelling. One other sign we can see is change of voice due to compression effect of swelling on the larynx. We can also see sympathetic overactivity like Horner's syndrome. Now, and we can also see for Pemberton sign. In palpation of thyroid gland, we have to also look for the next lymph node. Lymph node are important because some carcinomatous thyroid swelling show metastatic lymph node.
Hello everyone, myself Dr. Dhruvin Shah, ENT resident. So continuing with the case of thyroid swelling, here I am demonstrating auscultation and percussion. So in percussion, in thyroid swelling, we usually do percussion on the manubrium sterni, and we see if there is any dull sound coming from it. Because behind the manubrium sterni, usually there is trachea. So in percussion, in normal patient, there is a resonant sound, but if there is a retrosternal goiter, so the dull sound will come. So this is the landmark for manubrium sterni, and we are percussing it. So here there is a resonant sound, so we can say we can rule out the retrosternal goiter. So in auscultation, we use stethoscope to hear any bruit on the thyroid swelling. So in primary toxic goiter, due to increased vascularity in the swelling, we usually hear bruit. So in this case, there is no bruit heard, so we can easily rule out primary toxic goiter. Thank you.